decades, women's health conditions have been chronically underdiagnosed, misunderstood, and underfunded. My guest today is working to change that. Gregory Miles is the founder and CEO of Milestone Gyno-Mics, a biotechnology company developing a non-invasive AI-powered blood diagnostic platform focused on detecting women's health conditions earlier and more accurately. With more than 15 years of experience in biotechnology, diagnostics, and artificial intelligence, Gregory is tackling one of healthcare's biggest blind spots: the years-long delay many women face before receiving a diagnosis for conditions like endometriosis. Today, we're going to explore the future of diagnostics, the role of AI in medicine, and why the next major healthcare breakthrough may not be treatment, but rather early detection. Welcome to the show, Gregory.
Yeah, thank you so much for having me. I really look forward to the interview.
It's my pleasure. Why don't you just kind of take us to the origin, to the journey? Like, why did you decide to focus on women's health and in particular endometriosis?
Yeah, a good question. So I decided to go after this mission because I grew up in New York City, and I lost both my grandparents as a teenager. They both passed away from leukemia, and unfortunately, they caught it too late. And so my 8-year-old daughter Sydney was unable. She didn't get the chance to meet them, and it's because early detection wasn't available to them. And so as a result, I decided at that point I wanted to spend my career working on early detection, and I realized that there was a significant gap, that biology usually involves very large data sets, and biologists generally don't have the background to handle this data, and data experts lack the biology background oftentimes. So if you want to turn these large data sets into something that can be used in the clinic, it's quite tricky, and you need to sort of have this mix of those backgrounds. And so I decided at that point that I wanted to become one of the first bioinformatics PhDs in the United States. And since then, I've spent over the last decade plus, I've been working in genomics and diagnostics and AI to turn that biological data into something that can be applied in the clinic. And during all this time, a loved one was suffering from chronic pain, and she went from doctor to doctor, but no one really could figure out what was wrong. And after 12 years, a surgeon diagnosed her with endometriosis. And I just remember thinking to myself, why didn't they see this on the test they ran? What took so long? Like, I couldn't figure out how we ended up in this place. And I realized that early detection is completely missing from women's health. With the exception of breast cancer, women's health just does not have early detection. And carrying that forward, my daughter is genetically high risk for endometriosis as well, and she needs better solutions so that she doesn't spend her entire 20s begging doctors to take her seriously. And so I left a job that I had for the last 10 years at Agilent, and I founded this company, Milestone Gyno-Mics. And as you said, we're building the first AI-driven early detection platform for women's health, and the first target is a non-invasive blood test for endometriosis, so that women can get diagnosed at the first onset of their symptoms.
Yeah. Gregory, without getting too technical, are you able to kind of reveal how the science works? Where do you acquire the data to be able to drive the early detection?
Yeah, good question. So over the last couple of years, we've built some partnerships with some great folks on our team. Two of them are doctors Shanti Moling and Nick Fogelson, who are gynecologic surgeons that are in Portland, Oregon, two of the top surgeons in the world in this particular field. And they have generously offered to provide us with patient blood samples at no cost. We just paid for shipping in order to test our methods. And the key to what we're doing is, based on my story, it would sound like that I would have gone into oncology research with my grandparents and all that before what happened with the endometriosis story. And I did spend most of my early career in oncology, and I realized that they learned a lot of lessons the hard way. It took 80 years for folks to realize how complex the disease was, and for them to realize that they needed to understand the biology better and use uh, more complex tools for diagnosing it, things like genomics and artificial intelligence. And once that happened, everything else unlocked. So in the late 90s, early 2000s, oncology realized that understanding that biology, the complexity, that cancer is not one disease, it's a collection of diseases that all behave differently, but share a certain set of hallmarks.
Hmm.
Once they did that and they identified how it worked, everything else changed. There started to become more targeted therapies, preventive care. Insurance coverage is pretty universal for anything that's not experimental at this point in the oncology space. So seeing all that, but seeing how long it took, um, made me realize that like we need to apply the learnings and sort of fast track this in women's health and try to figure out if there's ways to understand the complexity. And so what we do is we look at three different types of signals from the blood, not just one. And a lot of companies, they start by looking at one type of signal, whether it's a certain kind of protein or a certain kind of marker. We look at three different signal types. Some of them are coming directly from the disease, and some of them are coming from the body's natural response to the presence of endometriosis so that we get the
Hmm.
complete biological picture. And that's what cancer figured out about 10 years ago and in their blood-based diagnostic journey. And so we're trying to repeat that here.
Understood. So for our listeners and viewers, do you mind kind of answering a two-fold question? One, what is endometriosis? Like I mean, you and I chatted, so I have some understanding, but do you mind specifying, kind of describing what it is? And second, because what I'm hoping is that through your descriptions, maybe more women become aware and specifically seek guidance around this diagnosis. And second, was it the personal connection for you that convinced you that we ought to focus on this, or was it kind of like the fact that your relative spent 12 years going undiagnosed and trying things that didn't work? Kind of walk me through it.
Yeah, so yeah, that's a good point. We should start at the beginning. Um, so endometriosis is a chronic disease that causes a wide variety of symptoms. It's caused by cells that are similar to that of the uterine lining, the endometrium, that end up in other parts of the body. So you can have these cells that are like those in the endometrium end up in your intestine, in your colon, in your lungs. It can even end up in your brain and spine. Those are a little bit more rare, but these cells end up in places that they shouldn't be, and as a result, they end up causing chronic pain and gynecologic symptoms, but also it's the leading cause of infertility. It causes 50% of infertility cases. And surprisingly, it impacts more than 1 in 10 women worldwide. So it's the number is
Mhm.
probably closer to 1 in 7 or 1 in 8. And yet, most folks don't even realize they have it, or some folks don't really know what it is. It's one of these areas that's just there's been a blind spot to it for a very long time. Many women have just been told that it's normal to have period pain like this. It's normal to have painful intercourse or to just deal with it. And the worst, and what I've seen with many of the patients, is that they end up being told by their doctor that they're imagining their pain and that it's all in their head. And
Wow.
so it's really unbelievable that we're in 2026 and that's still, that's where we are right now.
Hmm.
The symptoms are very non-specific, so you can't just bundle them all together. And the care is separate too. So you can end up going to a GI doctor for what you think is Crohn's disease or something inflammatory in your bowel or your intestine. You can go to an OBGYN because of your painful period. You can end up going to a surgeon because you think you have appendicitis or gallstones. And when they proceed with that procedure, when they go forward with that procedure, they can't figure out why you're still in pain afterwards. And
Mhm.
so at that point, a lot of times that's when they may tell you that you're imagining it. So um, the most important part of this is that more than 95% of the time, you cannot see the disease on imaging. So you can't really screen for it. You can't really test for it in any way. Generally, it's a diagnosis of exclusion unless you are one of the 100 or so world experts who know how to identify the disease just from an interview in 10 minutes. And so, for example, the two surgeons that we're working with that are getting us, they tell us, yeah, we can identify endometriosis 99% of the time just by talking to the patient for 10 minutes. But that's not really the norm here.
Mhm.
And so for that reason, the diagnosis becomes delayed. Most primary care doctors and OBs do not want to suggest surgery as a
Yeah.
first line option, which is the only way to really diagnose it definitively. So patients will end up going on these diagnostic odysseys where
Mhm.
they get misdiagnosed with all sorts of conditions before they finally, if they're lucky, see the right person who can suggest something, something that's gynecologic or some endometriosis. And it's an inflammatory disease. There's been a lot of debate about what the root cause is. It's still not really known, which
Mhm.
is why our company uses the cancer analogy so frequently. Our whole motto is women's health conditions like endometriosis behave like cancer, so we should diagnose them and treat them like cancer. Cells that end up in other parts of the body, that's how cancer behaves in certain ways. And the damage that it causes, the outcomes, all of that is very similar to the way that cancer operates. And only in the last several months, a paper came out that showed that all 8 hallmarks of cancer are shared by endometriosis. So we're talking about growing your own. They grow their own blood vessels. They avoid the immune system. They have the cells grow uncontrollably. All 8 of the key hallmarks of cancer are also shared by endometriosis. And so the fact that we are not treating this with the seriousness of
Mhm.
a disease like cancer, to me, is frustrating. You asked,
Yeah.
how did I get here? Is it the personal story? It is. That's a big part of it. When I was working in the oncology space, I was trying to develop a blood test for cancer while seeing this person go through that struggle and realizing that there are answers here if we can just diagnose people, especially diagnosing them early. There are
Mhm.
treatments that are available. They're not perfect, but the earlier you catch the disease, the better those treatments work, just like in cancer.
Yeah.
And so there were a few different reasons for why I felt like this was the direction to go in. The personal story, the biology made a lot of sense. The access to samples, for free samples, because folks they just needed this so badly that they were offering to give us free samples in order to push this forward. The
Yeah.
movement within the community was very, very inspiring. So we were very pleased with that too. And so it allows us to develop this thing faster and cost consciously at the beginning, so we can show that it works. And so that's sort of what we're finalizing now. And July 1st is when we expect to have our pilot study results. And once that comes out, then we're going to raise an institutional round and run a larger study and launch.
Amazing. So, I mean, the obvious questions for me is, twofold. I guess I'm starting off with twofold questions, but one, you said this is a chronic condition. I'm curious if this could be a terminal condition. And two, if this is a chronic condition, then in your case, somebody went undiagnosed for 12 years. What does it like? Um, what does a delayed diagnosis actually cost society? Not just financially, but emotionally and economically. I mean, I would suspect that it's got to be pretty debilitating when a woman is in pain.
Yeah. So I'll start with the first question. So when the disease is allowed to grow and spread, the likelihood that it invades the neighboring organs is higher. So I know many folks who have had these what they call lesions, endometriosis lesions. They're basically the types of scarring and growth where the endometriosis cells should not be. These cells can end up in your colon, for example, and I know folks who have had part of their uh, part of their digestive system removed as a result of this. So it's slower moving. It doesn't have the immediate urgency the way the cancer does, but the longer you wait, the more damage it does, the further it can spread, and like cancer, the harder it is to have the treatment work. So if you were able to treat endometriosis in the first couple of years of experiencing the symptoms, it's more likely that hormone therapies will work. It's more likely that the surgery you have will take,
Yeah.
because you have to have surgery to remove those lesions. If you wait longer, it's possible that you don't get it all, and then it can grow back. And so in
Yeah.
about 30% or so of the patients that have surgery, it comes back. And I can tell you one story. So on our team, we have Abby Finkenauer, who is Congresswoman from Iowa, who's a women's health advocate, and passed some amazing legislation, came out with her story of endometriosis. Her parents believed her, and they pushed things forward very early in her life. And as a result, 3 months ago, she had her first child. And so that's the kind of difference early detection can make in this space. Whereas I've spoken with folks who didn't get diagnosed for over 30 years, and they said they forgot what it was like to be out of pain. They missed their window to have a family. It was devastating. And so I would say that there was almost a universal agreement when I asked the community, what would a non-invasive test have done for you if it was
Yep.
available? And 99% of the folks said, yeah, this would have changed things significantly. Um, and as you said, there's financial implications too. So and it goes toward there's several different angles. I know that there's like a business aspect of this podcast. So
Mhm.
if you're talking about just simply lost productivity and medical costs, you're talking about $200,000 per endo patient over the course of the 10-year diagnostic delay
Wow.
for every missed patient. For the OBGYN, reproductive experts, you're talking about a lot of IVF treatments that were doomed to fail before they even started because they didn't diagnose it. So you're talking about probably about $2.4 million in failed protocols per practice if you're dealing with about 100 couples or so every year. So that's a huge cost, not to mention the additional clinical services. On the primary care side, you're talking about all these extra visits that are unnecessary. That adds up to a couple $1,000s a year. There's also the insurance companies, in terms of how much excess cost there is. If they could spend even $2,000 or $3,000 for a test like this, like we would like to price it lower than that, but even if they ended up paying $2,000 or $3,000 for this kind of test, you're talking about cost savings of about $55,000 per patient, and that's
Wow.
including and that's include. So that's obviously that's a significant incentive for them to want to
Of
test
course.
rather than going down this rabbit hole of diagnoses and doctor's visits and ER visits. I mean, I can't tell you the folks that I've watched how many times they end up in the ER with pain, and so that just add up. And so there's a lot of financial benefit for a solution like this as well.
It just, I mean, you stacked a whole bunch of patient costs. And did you say 1 in 8 to 1 in 10 women suffer from this?
Yes, it's
Wow.
the
That's
statistic
a
is
bad.
1 in 10, but the expectation is that there's probably a lot of undiagnosed women out there, so it's probably closer to 1 in 7 or 1 in 8.
So back of the napkin calculation, if there's 400 million people in the United States, 200, let's say that 50% of them are women, so that's 200 million. If it's 1 in 10, we're talking 20 million women maybe suffering from endometriosis in the United States.
About that, so I would caveat this is that endometriosis tends to stick with reproductive age women.
Okay.
So young girls mostly I'll say don't get it until they're in their teenage years. And
Yep.
there are a lot of folks who, when they have endometriosis and hit menopause, that the symptoms do resolve for them. But generally we stick to like 15 to 45 or so. Like the range for our study, I think, is about 18 to 42 for the women that we recruit into our study. So it's probably a little bit. Yeah, it's not quite 200 that much, but it's a
But
lot.
but even if half of the women were in the reproductive age, that's still a very significant number. I mean, it's two white guys on a podcast, but would this have been the case if this was a man's disease?
No, and that's I mean that's where cancer again. Cancer comes in. Like obviously, cancer is devastating, and it's horrible. But I can tell you that if you take an example cancer, say colorectal cancer, which impacts, I
Yep.
believe, 32. There's 32 new cases out of every 100,000 people. So we're
Okay.
talking about quite a low incidence rate, right? But Cologuard is out there, and there's screening for it, and there's a movement behind different cancers. You know, breast cancer was the first big one back in the 90s. Everyone just got tired of their wives and their sisters and their moms dying of this thing. And with colorectal cancer, the incidence rate is so low. And so imagine for a 1 in 10 incidence rate, or if you want, if you want to make it a little bit lower because it's only reproductive age. So the fact that a lot of women don't even know what it is, and I know women who said, yeah, my mom just said this is normal. Like even their mother is saying it because they didn't understand it because they were told just deal with it. And so yeah, we're two white guys discussing this on two white men discussing this on a podcast, but yeah, there's no way that this would have gone on for this long, and if this was a disease affecting whole population or men, and it just continues to push forward some of those inequalities that have been persistent. I mean, there's stories about women getting sent home from the ER with heart attacks because their symptoms weren't the same as what had been expected.
Wow.
There's different drug studies. I think it wasn't even legal to include women in clinical trials until like the 90s, I think. So they did like experiments on ovarian drugs using men as the safety study cohort. I mean, there's just some unbelievable, disappointing, history here. But again, we're in 2026, so you figure it shouldn't still be like this, and it is. So it's time that we kind of change the dynamic here and change the story.
So from your perspective, I mean, like I'm kind of curious. Another two-fold question, but do you view that women's health gap is primarily a scientific problem, a funding problem, a societal problem? And then the other question, I think I know the answer to the second question, but like if I understand correctly, the intent behind Gynomics is to build out the platform, but the platform is not necessarily just limited to endometriosis. It's to be able to identify other women's diseases.
Yeah, it's a loaded question because there's a lot of different factors that go into this. I would say that all of the above sort of fits the right answer to that. I would say so. Genomics really wasn't popular until the mid to late 90s, early 2000s, and genome sequencing didn't really become popular until about 10 years after that. You're talking about 2006, 2007, 2008. And the cost was still kind of high at that point. And those are the technologies that really allowed cancer to move forward in that, with the progress that I described earlier. And so it's only the last 15 years that we've had the tools where we could really accelerate the type of work that we need. With cancer, the invention of imaging technologies changed a lot. You didn't have to wait until you could see or feel the tumor before you went and saw a doctor. And unfortunately, with these women's health conditions, you can't really see a lot of these conditions with imaging. So when you can't see it and the symptoms are very nonspecific, that's when some of the surrender, if you will, they just, I don't know what I'm supposed to do about this. The genomics gives us the clue. It allows us to see on the molecular level what's happening with the biology. but there's not a lot of folks who really know how to do that and also can apply it to like a clinical. It's only, again, the last 15 to 20 years. My education formally finished in 2012, and I learned how to use genomics for clinical interpretation and clinical application. But it's a very specialized field, and I think to be able to get the kinds of teams you need in place to answer these kinds of difficult questions, deal with the complexity of the disease and the biology and the data sets themselves, these are hard problems too. So you can say, well, I don't know why nobody came up with a drug for endometriosis sooner. Well, we don't know why it happens. So why don't we know why it happens? Because we haven't diagnosed it yet. We haven't diagnosed it properly. And so it's this circular, circular process where, or chicken and egg type of scenario, where it's really hard to break in unless you can find a way to visualize or understand the disease. But there's a significant social component to it as well. It's there weren't a lot of women in politics. There weren't a lot of women that were able to push this. I highly recommend everybody read the AOADX report that came out after JP Morgan in January on investors were very skeptical about the power of women's health startups to make return on investment. And there are three amazing founders of this diagnostics company, women's health company, that decided to reclassify certain companies as women's health companies to demonstrate that if you just call breast cancer women's health, if you just call reproductive health women's health, all of a sudden all of a sudden you're talking about billions of dollars in return. And so when investors give you the excuse, well, women's health doesn't make money, that's why I'm not investing, they can say, actually it does. Actually it does. You just don't realize that we're calling it oncology, we're calling it infertility, reproductive health, we're calling it autoimmune disease. This is women's health. And it's something that needs to be addressed in that way. And so there's a fight there, and it's important that we try to make the most of this moment because it's getting the attention. You see, I think Melinda Gates just allocated a whole bunch of money for women's health and menopause, and I think Bezos's ex-wife did the same. And during I think Biden's administration, they allocated a bunch of money for women's health too. We really need to kind of make the most of this moment so we can take advantage of it and get this thing moving ahead.
And so, I mean, obviously, the natural question for me that follows is, you have PhD in bioinformatics. How is AI helping you to accelerate the diagnosis?
Yeah, good question. So, traditional bioinformatics looks at different kinds of signals coming from the body, and it tries to interpret them. But there are large numbers of signals. We're talking some cases that can be with RNA, like what I'm looking at is one of them is RNA. There can be 20,000 signals or more that you're looking at, and you need to try and figure out which signals are important, which signals are just background or noise or just they're confounding in some way. So that's one way. There are other kinds of signals that can have millions of different kinds of signals, and so someone can't just look for that data in spreadsheets and pick out from a million rows or a million columns with hundreds of data points what might be important. You have you have all these different markers. They all have different scales. So imagine if you're like looking. I'll use a baseball analogy. So if you're trying to compare like a pitcher's number of innings with the batting average, like they're two different scales. Batting average is a percent. The innings are a count, a certain kind of count. So there's different formats for the data, and we need to be able to find a way to combine those together in order to make sense. So the AI, the machine learning, the traditional machine learning methods that are being used for this, they select markers of interest. They figure out the ways in which those markers contribute. So if you imagine you and your friend are moving a couch and you're really strong and your friend is not so strong. So you have to figure out how much is my strength contributing to moving the couch versus my friend. So weighting those things. And so the machine learning algorithms learn the weights for each of those molecules. Maybe there are certain cancer-related molecules that are really, really contributing to endometriosis, and then there are certain molecules, they only contribute to like 10% of the patients in a weak way, but they're still worth looking at. And
Yeah.
so the AI helps us to combine those into a signature that then can be applied for new samples that we see and to make a prediction that way. It's similar to the way Google image recognition. If you give it like 100 pictures of a cow and 100 pictures of a sheep, it figures out, okay, the sheep have fluffier wool, and the cow may have horns, and and the shape of the face is different, and it identifies like what features are most important for distinguishing between those images. And then you hope when you give it a new picture of a sheep that it can correctly predict that. And so it's about learning the molecules which are quantified that are most important in contributing, and then testing it with a set that hasn't been seen before and see like, how do we do? And goal for us is, with the pilot study, we'd like to get at least 80% accuracy. It's very modest, but because we're only dealing with a 50-patient pilot, it's quite a low number. Early signs seem to be showing that we're going to maybe do quite a bit better than that, which is promising.
Amazing.
Eventually, we'd like to get the performance over 90%, and I think that's kind of the most important thing. And if we can get there in symptomatic patients, then you're talking about a change in the average diagnostic odyssey from like 10 years on average to like under 1 year.
Wow. So in order to accomplish this, what's the biggest bottleneck? Just the ability to be able to acquire blood samples and ingest these through your platform and kind of determine like the biomarkers and be continuously reinforced and become more precise? Like, how can you accelerate the journey?
Yeah, so there's a couple of things I've learned along the way. At one point, I thought the blood samples were going to be the bottleneck, and they come at a certain speed. You're not going to get 200 of them tomorrow. But once you partner with the right surgeons, you get into a good flow, and you can have things moving along pretty reasonably well. The challenge that a lot of early stage founders run into in the biotech side. So with tech, you can sort of build something in your garage. You can code it in your garage. You can like eat ramen noodles and you not pay yourself for 6 months, and you can have some sort of minimum viable product that you can then try to get some customers to adopt. With biotech, you need to show that it works, and the experiments can't be done in your garage. You need a lab, you need samples, and you need consumables that you can, whether it's antibodies or other kinds of markers or test tubes or pipette tips, like all sorts of disposable things that cost a lot of money. And so finding a way to be lean about that and be responsible while still making sure that the science is good is probably the most difficult thing, because you're trying to explore an idea, not a prototype, an idea, and you're trying to get like a friends and family around to get to fund that based off of, that I can do this and the idea sounds pretty cool, but we can't just get in the garage and build something easily. And so usually the way biotech inventions come about is there's either someone does their PhD work and they spin it out of there, which they've been working for between 5 and 8 years on some project, making like $25,000 a year under their professor, and they can do it that way. Or they spin it out of a large company, or a professor can spin it out of academia as well. So for someone like me, I took an unconventional approach. This was not my PhD project, and I didn't spin it out of a large company. So the largest bottleneck was probably a combination of financial and trying to figure out the best ways to run this as lean as possible while still making sure it was scientifically rigorous. And we managed to do it. We originally thought we were going to need about $750,000 to run the study. We've done it. We should be able to finish with 150,000. We're only raising 250,000. So yeah, we really were able to cut it down based off of a significant contribution from the scientists we hired, Poppy who's just been amazing as well. We looked over the protocol and realized there were a couple of inefficiencies that we were able to remove, and that really saved us a lot of time and money. So
the question is, I think that the story is extremely compelling, especially the size of the market, the issue, like that this create the economic impact, social, emotional. But if and as you know, 50% of our audience is investor, 50% is founders. Like if there's an investor listening, who is the right investor to come in? Obviously, life science and biotech investors, but do you have somebody in mind?
Yeah. So good question. So I mean, we're closing our friends and family round. You know, that's a little bit smaller level. We've got enough to file our IP and finish our studies. And so the last funds would be used for a little bit of automation, a little bit of regulatory stuff. But the next round is what we're really looking forward to. So basically, since January 1st, we've raised this small round. We've hired the scientists. We rented out the lab space in Palo Alto. It's a shared lab space, nonprofit, StartX Med. I'll give them a shout out. It's dirt cheap lab space. We're spending like $1,300 a month or something for lab space where all the equipment is there. We've been really lucky to be located in the Bay Area, so we could do it this way. And we've been making great progress. We sent out an update to our investor and non-investor community in the last week. We've sequenced nearly 20 samples so far of the 50 targeted that we have, and the results are looking quite good. So we envision when we finish the 50, our target right now is July 1st to release the pilot study information and accuracy results based off of that cohort. At that point, we will raise a much larger institutional round. So at that point, we're looking at women's health investors, whether it's VCs or angel groups. We're looking at diagnostic investors, folks who are looking in like the early detection space. So investors that are interested in that, we've had a lot of excitement from early conversations that we've had with investors like that who say, oh, we can't come back to us after July 1st, and we want to see like what the results are going to look like. So a lot of pressure on us to make sure that it performs the way we want it to, and you know, transparency is extremely important for us. So we want to make sure that, especially with the history in the diagnostic space and some of the stuff that happened with like Theranos and Elizabeth Holmes, we need to make sure the reputation is rehabilitated and that folks are fully privy to how the tests are doing. But yeah, so basically like in about a month, we're going to start raising that larger round. And so the institutional investors that maybe have already done this space, or an investor that's looking to unlock that women's health inflection point. We've had some folks who don't necessarily do directly diagnostics, but they realized, oh, this is a place, like this is what happened with cancer. We can replicate this here. So this is worth throwing a little bit of investment into, so we can propel it forward. And now that we've all nearly de-risked the science, you know, we're getting very close to de-risking that science fully. The next part will be running a larger study and running a larger validation and building our lab developed test. So another benefit of this space is that diagnostics don't really require FDA approval at this point. It's there's something called a lab developed test pipeline that allows you to go to market to get early adopters the opportunity to have the test. And you still publish papers with your performance. You still make sure that everyone's fully aware of how many samples you tested it on and what the performance was. But it allows you to not only get to market sooner, but it allows you to adapt the test. So if we're going to run, the next study is going to be about 250 to 300 patients. After we finish that, we're going to release the test as a V1, but we're also going to run 1,000 patients or more validation study. And if we can tweak that test, make it go from 92% to 96%, we can implement those changes and incorporate them into our V2 version, a V2 version of the test, and keep iterating. We can also build other applications into the test, like adenomyosis, polycystic ovarian syndrome, which is now called MOS. We can go into the infertility space, as well as post-surgical monitoring, so recurrence monitoring, which is what happens in cancer as well. So we envision this as a complete solution, not just for endometriosis, but for women's health early detection. And so by taking this non-FDA approach, we can keep adding new applications to the test as we go, and that allows us to reach more women and help a larger market and help a larger population.
How and that's amazing. I mean, obviously, it would be a huge unlock if we can go from episodic testing, especially non-invasive diagnosis, to something that, like, especially in this case, something that could be diagnosed earlier and dealt with earlier. How important, you talked about, like, that you're blessed with the fact that you're in Palo Alto, but, like, how important is that you're based out of the Bay Area and that there's just such confluence of innovation and capital in the Bay?
Yeah, I don't think I could have done this anywhere else. I think I moved here because of it. So, in 2015, well, 2012, I visited for the first time here, and I just fell in love with the area. I met some folks, and always loved how everyone's trying to build the next awesome thing here. And this is
Yep.
like the bio hub, it's the tech hub, but
Yep.
a lot of people really trying to do ambitious things and try to change the world in good ways, not only bad ways. And and I met a lot of these folks, and I realized that, like, this is the place I needed to be if I wanted to try and implement an ambitious idea like this. And a thing like StartX, where you can rent lab space for that kind of price with all of the
Yep.
equipment and the camaraderie there. Like, I've become friends with so many people in the lab, and then they have this incubator just next, right in the same space, where they have 3 or 4 cohorts a year where they try to introduce. It's mostly for Stanford folks, but they allow visiting founders to join if you have recommendations. It's just this ecosystem of entrepreneurship.
Hmm.
And I'll tell you, like, most of my friends and family around came from the relationships that I made there. It was just
Yeah.
like some of the friends that I've made there, some of the contacts and colleagues who I've seen how they work, they've seen how I work, and we just talk every day about how we're doing, the struggle, the pain, the good things. It's all combined in this uh, sort of like an emotional support group for folks who try to do these entrepreneurial types of
Yeah.
endeavors. And it's wonderful. It's something that I wouldn't really trade for anything. And of course, as you said, the funds are all here. So I'm throwing a couple of events in San Francisco, some dinners on the topic of how the next big liquid biopsy is actually going to be in women's health, not in oncology. And
Okay.
which is liquid biopsy is the term for blood-based or liquid-based disease detection, so non-invasive detection.
Yep.
So I'm hosting a dinner for investors, in San Francisco to do that. It's hard to do that anywhere else. People can just sort of leave work and come to our dinner, and we
Yeah.
can talk about where those opportunities are, and what a lot of the financial things that we've just discussed, like where's the return on investment, where's the
Yeah.
the opportunity and value.
So, with that context in mind, what is the metric or the signal that would give an investor confidence? Is it the accuracy rate hitting 90%? Kind of like, if there's an investor looking at Milestone Gyno-Mics, kind of like, what are the most important metrics they ought to look at?
That's a good question. So I would say that there's 4 main buckets that we look at our competitors and we say, how can we do it better than they do it? And these are the ones that I would encourage the investor to look at. So the first is blood-based approach versus some other kind of fluid or other. So there's companies that are doing modified types of biopsies. There's folks that are collecting menstrual blood as a marker, and those are still somewhat invasive. Folks with endometriosis, it hurts to collect menstrual blood. Like, a tampon hurts, a menstrual cup hurts. There's a lot of user error that can happen there. Also, if someone comes to their doctor and they have abdominal pain, that's considered a medical emergency. And so, is your doctor really going to say, all right, we should go to the hospital. We'll test for gallstones and appendicitis, some sort of immune issue or infection. And in 2 weeks, when you can test for endometriosis, then that's not realistic. Like, you're not going to wait 2 weeks, 3 weeks for that to happen. So one of the aspects is, I think, the peripheral blood, which is blood from your arm. That approach is going to be very important for a diagnosis. The second one is to be mindful of is, does this make a binary decision, or is it something called the traffic light system, which is a red, yellow, green. Red is, you have the disease, green is you don't have the disease, and yellow is we don't know. It's okay to have this, but your cohort for that shouldn't be very large. And there are a lot of companies who came out and they said, we have 90% accuracy, but they don't tell you how large the yellow light cohort is. Yep. And if they don't tell you, it's likely 30%, 40%, 50% of the patients. No insurance company is ever going to pay for that. And most folks who are desperate for a solution are not going to pay out of pocket for that either. So that's another one. I would say that when you're looking at the biggest metric is going to be sensitivity and the two are going to be sensitivity, specificity. So the sensitivity is going to be how many cases do we catch versus how many do we miss. So if there are 10 patients with endometriosis, can we capture 9 of them? That would be pretty great. If we capture 5 of them, that's not so great. But then you have specificity, which is of the patients who are healthy, how many do we correctly identify as healthy? And so if there's 10 healthy patients, can we identify 9 of them as healthy? That's pretty good, as long as your incidence rate is okay, and I can explain that later. But if your sensitivity goes up, usually your specificity goes down, and vice versa. So it's a challenge that happens in machine learning and most statistics. If you try to make your accuracy on one side better, the accuracy on the other side gets worse. So oftentimes the question is, which one do you pick? Would you rather miss a few cases of endometriosis, or would you rather scare people into thinking they have endo when they don't really have it? And so in cancer, this is a significant problem. They've decided to err on the side of avoiding false positives, so falsely diagnosing patients versus correctly diagnosing patients. In this space, I would think that it's probably better. That's probably a similar approach that we'd want to take. We don't want to send folks for unnecessary surgery.
Of course.
But oftentimes, the patients who already have endo but don't know it will end up just going through the same process they're going through right now. And so it's probably better to err on the side of the specificity, making sure that the people that we say have endo definitely have it versus overcorrecting. So that's one of the keys. And then I would say the other key bucket is you want to make sure that the AI algorithms are correctly testing on patients who have never been seen by the learning algorithm before. And this is something that we've seen from certain companies where it's like, again, going back to the cow and the sheep analogy with Google image search, it's as if you gave as your neck, so you've trained it on 100 of each picture, and then you give it one of the pictures it already saw. And so basically it can memorize the answer rather than actually knowing what a picture of a cow looks like. There are a couple of companies that have done this, and so that's something that investors also want to ask when doing their due diligence here is, what is your AI algorithm doing, and what does your held out set, your independent data set look like, and is it truly independent from the learning algorithm that you've built? And so I would say that is really critical as well for them to ask about.
If we're having the same conversation 10 years from now, Gregory, what breakthrough do you hope that we're celebrating?
My ulterior motive in this, so we said, like, diagnosis accelerates everything.
Yep.
So my ulterior motive is that by looking at all of these, they call them multi-omics, but it's basically like all the different signals that we're looking at. By looking at these signals, I think we can find signals that either we haven't seen before that may be indicative of drug targets, or we may see signals that we have seen before, have been identified as drug targets, but not necessarily for the disease that we think. So the biggest one that we see now is like Ozempic. So at first it was a diabetes drug, and then they realized, oh, this thing helps women and men and everyone lose a lot of weight. And then they realized, oh, we're starting to see, like in patients with Alzheimer's, that when they're taking Ozempic, it's, or any of the GLPs, I shouldn't just stick with Ozempic, that they are they're slowing down that it's actually helping a little bit with that off-label, as sort of a collateral type of effect.
Yeah.
And if you look up endometriosis and Ozempic, you'll see that there's a little bit of promise there as well. And my hypothesis, it's starting to be, I think, validated a little bit, is that most of the most horrific diseases are inflammatory processes that are either out of control in one direction or out of control in another. Yeah. And so with cancer or cardiovascular diseases and strokes and diabetes and dementia and Alzheimer's, but also endometriosis, I think they all fit into this inflammatory type of process. Yeah. Ozempic reduces inflammation. So of course it's going to reduce inflammation for folks who have inflammation in their brain. It's going to reduce it for folks who have inflammation in the uterine lining or in other places. There's this overarching inflammatory theme. So it could be Ozempic or GLP-1s, but I do think that we will find markers that will be more specific than that. Maybe there's some kind of drug that targets osteoporosis. Who knows? I know that in the last 6 months, UCSF came out with a fascinating paper that linked 600 different diseases as comorbidities with endometriosis.
Wow.
So that means that patients with endometriosis are more likely to experience one of those diseases. And many of those diseases have nothing to do with gynecology. There were eye conditions. There were migraine headaches is the most common one, but there's eye conditions. There were certain kinds of cancers. So this comorbidity thing means that this is a systemic disease, which means that there are likely drug targets that we can use that we just haven't figured out can be applied in that place. So is it possible that one of these drug targets and one of these drugs that's being used for some random disease that we never thought about could be applied for endometriosis? I think that's a way to faster track. That's a faster track to, you already had the safety studies, you just sort of jump into a phase 1 trial, and in a few years you may have something that's actionable that goes beyond the standard treatment, which is hormone therapy, really severe hormone therapy, or the surgical option, which is either excision or hysterectomy, which is about 90% effective.
Wow, amazing. I know that we're coming to the end. My favorite question to end the show is, and you can pick, what's the best advice you've ever received, or what's the kindest thing somebody has ever done for you?
I would say for the first question, it would be one of my close friends. He said, in the entrepreneurial world, you need to look for the side, that like the front door and the back are not going to open for you the way that the side door was. And when I was doing cancer diagnostics, we were having this trouble because you need cancer samples and they're very expensive. And we didn't have the money to pay for them. And one day, this friend came to me and he said, what if you tried to demonstrate this in dog samples first? Yeah. He's like, you can get those samples for free. It's just this side door, the side door approach has, it was such a genius. He's not a biologist, he's not a he's a chemist. And he just came up with this idea, and it was just so brilliantly simple. And so now, like, no matter what I do, I always look for, like, is there a way for us to kind of take that side door in? And it's been eye-opening. It helped me find it helped me find a lot of the paths in this current journey, whether it be getting the samples for free now, or having a scientist on board and having them save us all this money, like getting the passion involved, but also like finding people who can help in the right ways has been like a really useful side door for me and for the team, and so that's been really great. And I think in terms of the kindness, I think there's just been so much kindness throughout all of this. I've spoken with so many folks in the endometriosis community, advocates, policymakers, patients, and I want to hear everyone's story because they're all slightly different, and they're all wanting to help. Even the folks who really can't help, I found that the ways that I need help, that community can help in certain ways, and then there's other ways where that just doesn't work. But they all want to help, and they all really want to see this happen, and they really want to see this succeed. And I am trying to have this company sort of practice that way. I want everyone to win from this. If I end up with a few less percentage points of equity, and it allows everyone who participated to win from this, then I'd like to repay that kindness in any way I can. And but it's been so much, I can't even name it. It's been so many of them. So it's been wonderful to see, and
That's
I really want to pay it back. Yeah.
That's fantastic. Is this unique to the biotechnology community in terms of like people being so magnanimous and supportive of one another?
I think every community has some of that, and then there's always going to be the diversity of bad actors or folks who are a little bit less in that boat. I think I try to operate with the way I want the world to be, and I try to put that good out into the world. And I'm not naive. I understand, that once you get into VC space, you have to be act in a certain way and be a little bit tougher. But I want to make sure that I try to hold those principles and the values that got me here, and hopefully it works. I think bio has been good about a lot of that. Even when I was in my full-time job, I remember if you just explain folks why things went wrong, most of them will accept the fact there'll be a little bit of a delay if you just upfront and you talk shop with them a little bit, rather than giving them some nonsense about or jargony type of response. So I've learned a lot from all these different worlds, and even the corporate world. It taught me a lot about different kinds of people and how to figure out what works best for them. And so I've just learned so much, and I'd like to kind of put that back out there. And I think there's people like that in all of these different spaces. I think you just have to find them, and
amazing.
Get blinded by a lot of the stuff the media throws out, and you kind of see all the bad stuff. And I think there's a lot of good ones out there, and we should highlight those more.
100%. That's a great note to end on. Really enjoyed the conversation. Thank you so much. Hopefully we can spread the story around this disease, and with the story driving reach, hopefully we can find the right investors that can back the journey, back the mission, and drive to cure much sooner.
Yeah, that would be wonderful. It was amazing being on here. Thank you so much for inviting me. If anyone has any questions, you can reach me at greg@milestonegx.com, and you can look me up on LinkedIn. I'm happy to set up a chat with anyone who wants some more information. But yeah, thank you so much for having me on. I really enjoyed this, and I look forward to coming back to you when we have some results, and hopefully we'll have something else to talk about.
Absolutely. Thanks, Greg.
Thank you.